Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor for the University of Kansas Medical Center. Welcome back to Open Mics with Dr. Stites. Your genes contain clues to your health. As we learn more about genetic variants tied to certain health conditions, we can use those clues to tailor treatments to each individual. And we can be extra vigilant with screenings, catching cancer as early as possible. And that's what precision medicine, what I feel is the future, the golden future of healthcare, empowers us to do. Today we're learning about a genetic syndrome that doesn't guarantee cancer, but really significantly raises the risk of some certain specific cancers. We're going to meet a brother and sister who are finding out what those risks mean to them and to their family. And we'll meet one of the world's leading clinical cancer genomics researchers. That's a big turn of phrase there, genomic stuff. That's about research into this type of hereditarily linked disease, especially in cancer. Here in the studio with me is Dr. Jeffrey Weitzel, an oncologist and a clinical geneticist on the forefront of precision medicine. Good morning, sir.
Good morning, Dr.
Thanks for being here. We are proud to have him serve as Director of the Precision Prevention at the University of Kansas Cancer Center. Also here, our brother and sister, Aaron Moser. I got it right.
Yes.
All right,
yes,
awesome. And Angela Valent. I got that. That's a lot easier. I don't know about that other one. Who came to see Dr. Weitzel after learning they had a hereditary cancer syndrome. Welcome to you all. Thanks for involvement. Thanks for being here. Connecting virtually is Caitlin Schwager. I got that right, Caitlin?
That's right.
Excellent. Caitlin is a certified genetic counselor and coordinator of the SPOT Clinic at Children's Mercy, Kansas City. SPOT stands for Surveillance for Predisposition to Tumors. Good morning, Caitlin, and thanks for being part of our program today. Okay, here's the big one I'm going to mispronounce. We're talking specifically about Li-Fraumeni syndrome. How was that? I got it right. Okay, I do rehearse that a little bit before we get online. I've been coached by Dr. Weitzel, so just say LFS. Everybody's going to call it LFS, but I'm going to say it one more time to prove that I can do it 2 times in a row. Li-Fraumeni syndrome was first clinically identified in 1969 and given a name in 1982. It was linked to a specific gene in 1990, and today, genetic testing is finally affordable enough that we can identify people who carry the genetic variant and help them catch any possible cancers as early as possible. All right, Dr. Weitzel, this syndrome is caused by changes in the TP53 gene. Easy for me to say, but talk to us a little bit about what that means, what does it do, and how does a mutation raise the cancer risk?
Those are all great questions. TP53 is perhaps one of the most important and most frequently changed genes in cancer. It's often called the guardian of the genome. I mean, there's a huge title for it, a lot of work, but it's involved in genomic stability. And so it's really at the core of most of the biology of the cell. It's what makes a cell die when it's acquired mutations from other causes so that it doesn't become a cancer. So you can imagine that when that gene is inactivated, which it somatically gets inactivated periodically, quite commonly as an acquired change in other cancers, but in this case, we start with one step in the genome. The second step is acquired. And that gene opens the path for the development of cancers. And several things are quite singular about this syndrome. One of them is extraordinarily young ages. So it affects the young and the old. And I'm so glad to have Caitlin here at Children's Mercy because it's a partnership that we're here to commemorate today as well. But it's a very important gene, and we're just learning how to try and target it.
So, and I understand that, or first of all, Li-Fraumeni predisposes people to a higher risk of certain cancers. What type of cancers carry that much higher risk associated with that?
Yeah, and this is one of the earliest known rare cancer syndromes. And by the way, you've heard of BRCA, and I know you did a great program on Lynch syndrome recently. So 2 of the more common hereditary forms of cancer. But this one is quite rare. It takes essentially everybody working together to study it well, where they have 30, 40, 50,000 BRCA carriers, 2,000 P53 carriers.
Okay.
So it's a log value more difficult to study. But nonetheless, the cancers that we worry about in childhood, and it's different in childhood and adulthood, but in childhood, adrenocortical carcinoma, so the adrenal gland tumors, very rare in general population, sarcomas, so bone tumors, soft tissue tumors, and then the other one is brain tumors. So probably some of the things we fear the most in oncology and are the most disruptive. So there's really an important element of finding these things early when we can make a difference. So childhood and then in adulthood, just as one of our guests has experienced, it's breast cancer is probably the most important thing that transitions into adulthood.
So I understand there are phases of the syndrome based on age. Elderly starts at being 45 years old?
Well, actually, I wouldn't call elderly 45, but the transition is actually at 18.
Okay.
And so adrenocortical carcinomas, which Caitlin will be busy looking for in her clinic at Children's Mercy, and the children who have this, we can stop looking for it at that point. For whatever reason, it's developmentally related to puberty. And once you get past that, that window of susceptibility walks away. And it's really interesting biologically, we don't understand it yet.
Yeah, and there's a graph demonstrating
Yeah.
the different ages and how these things kick in. So it's kind of like you say, if you get past that certain age, all of a sudden the numbers drop off pretty significantly.
Right. And the thing that goes up is breast cancer in the 20s to 40s. And then for the, if you want to call it the elderly at 45, I'm not sure I would give
Let's
it
not
that
say
name.
that.
But
I'm 65. We're not
Yeah.
calling elderly 45. We're calling it 95.
yeah, but in men, perhaps gastric cancer. So a lot of the common cancers, lung cancer, for example, can be seen in Lee-Fermani syndrome as well. So it's one of the few inherited forms of lung cancer.
Wow. So now, Angela, you were just 39 when you learned you had breast cancer now. How old are you now today, and how are you doing? I guess I shouldn't ask how old you are today. I thought I said that. Really what it just says is, how are you doing? You don't have to answer the first part of my question.
Well, I'm
though.
40 today. So
Are you really 40 today?
Yes.
It's your birthday?
Well, no.
Oh, I was
My
like,
birthday
holy
was,
cow, I
but
was going to sing. You don't really want that
today
to
I
happen.
am. Yes. So yeah, I'm 40 now.
Okay.
Was 39 when I was diagnosed.
All right.
I am doing well. Went through 6 rounds of chemotherapy, double mastectomy, having reconstruction later this week, actually on
Okay.
Friday, and currently doing immunotherapy.
Okay, so that's quite a journey. And
Yes.
what does your journey look like going forward as far as trying to survey to see if it comes back, or what other chemotherapy or immunotherapy will you have to do?
So the immunotherapy will go through the summer, and then as far as monitoring, I'll just see my oncologist every 3 to 6 months, I think, for 5 to 10 years, depending on
Till that gene
things.
gets shut down,
Yes.
right? We
And
want you to
then-
be elderly, and then you don't have to worry as much. Is that,
yes,
that's
and then
the
I see
plan?
Dr. Weitzel every 6 months as well. And
Has he fixed your gene yet?
not yet.
What's he doing?
I know.
Well, I gotta get him on the stick there. So how did you learn that the cancer might have something to do with the gene mutation, or to this whole story for you?
Yeah, so because I was under 50 and got breast cancer, and because our dad had pancreatic cancer, was basically a trigger automatic genetic testing.
Okay.
So underwent genetic testing, and honestly, I didn't think anything would come of it, but found the Lee-Fermani that way, and to me, I think that was even a bigger blow than the cancer diagnosis, because then it's not just affecting me, it potentially is affecting my siblings, it's
Right.
my daughter, so I think that was harder for me than the cancer diagnosis, actually.
And I just want to say that loud for me anything just rolled off your tongue like you were saying it first. So that was impressive. Now, you shared some photos of you, your siblings, and your dad. How did you break the news to your family?
Well, I text all my siblings, and then, my mom and everybody that I felt should know to get tested, because obviously at this point we weren't sure if it was my mom's side or my dad's side, and so I have siblings on both sides, so I
Yeah.
think it was important for everybody to know so they could, get tested, and they can kind of start the
process and find out. So now, Aaron, you got a genetic test and learned that you carry the same TP53 mutation. What are you at risk for? What did you do next?
Well, I know I'm at risk for colon cancer, I believe, and after we learned it, we started scheduling everything. We tried to find a good doctor. Well, Caitlin actually got me on with Dr. Weitzel, and he's pretty much changed everything for me. So We've done a full body MRI at this point, and then I have a colonoscopy coming up later this month.
Okay, so you're trying to get the whole big screening thing done to look for any possible cancer. So Dr. Weitzel, MRIs are usually focused on a certain site, the brain, the spine, a certain joint. How helpful is a whole body MRI in a situation like this?
Well, for all the potential things we're at risk for, it's essential to do the whole body. And one of the things is that you need to be at a specialized center for this because it's not trivial. Normally they'd piece together all these various things that you've mentioned. But we literally go from head to toe, and you go rapidly, so it's not, you're not there all day. But we're looking for the bone, the soft tissues, the brain. In women, we do separately an MRI of the breast, just to get that absolute essential screening acuity out of that for those that are at risk. But the whole body MRI is one of the keys. And in fact, Dr. David Malkin at Toronto, they sometimes call this the Toronto protocol. He's at Toronto Sick Kids, and they were the first to demonstrate an improvement in mortality. So it's hard to find a rare syndrome, get enough evidence to prove the worth of this interventions.
Well, the problem is, of course, that you think, well, I found this cancer early, but did I really shut off cancer?
That's right.
So that's really important evidence that if you screen, you find it, you can actually help improve the work. Well, that's a big darn deal.
And it was critical because you can imagine, as you know, so much in transactional medicine, we have to get coverage, and this isn't cheap screening. So it demonstrated that worth, and we've really been grateful to have tools to work with in this setting that we know will benefit families.
And just to say, fortunately, the new MRIs that are coming out are probably going to reduce the time in there, just in case you think about this, by about 80 or 90% in the future. So then you'll be a little bit faster, because for those whole body screens for a while have been taking like a few hours maybe or longer, and that machine just goes bum, 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 for like a couple hours and you're in there, right? It's not the best sound effect. Okay, Aaron, you have a daughter. What does this mean for your daughter?
Well, she has had a full body MRI as well, and then every 3 months she gets a abdominal ultrasound, and then we meet with her doctor, I think twice a year as well, and then with Caitlin as well.
That is a big darn deal. So let's bring in Caitlin Schwager, the certified genetic counselor at Children's Mercy. We mentioned it before. She runs the Spot Clinic surveillance for predisposition as tumors. Caitlin, genetics and genomics are complicated. Help translate that into useful information for folks like Aaron. And anything else you want to talk about related to Aaron and his daughter?
Yeah, it was a pleasure. First, it was a pleasure to work with Aaron and Angela as they sort of try to navigate all of this with their children as well. But I think that's really one of the most important roles of the genetic counselor, and what we're trained to do is to take the complex information that we can get from genetic testing and all the implications that come with it, and help turn it into information that's useful and accessible for people from a wide variety of backgrounds. So I do feel like an interpreter of sorts much of the time.
So some people with these hereditary syndromes may never develop cancer despite the higher risk. So how do you balance the useless knowledge versus needless worry? And I know some people, and I've had some patients say, I still want to get tested because I don't want to have to worry about it if I know.
Yeah, that is certainly one of the biggest challenges with hereditary cancer syndromes in general, really, that, we don't want to pass up an opportunity to be proactive and catch things early. But the trade-off is that we often spend years looking for cancers that may or may not develop. And in addition to lab work and imaging and all of this, we often tell families and patients to have a low threshold to investigate changes to their health, just sort of in the interim between scans. And that can be really hard for families to balance that, to navigate what's worth investigating and what's not, because many of the symptoms that they would report to us, things like headaches or abdominal pain, can have a lot of other causes, often benign causes. But because they can be a symptom of something bigger, it can be really challenging to balance all of that, and navigating it can really cause a lot of anxiety for our parents, as well as our teens and some of our older children as well. They really do absorb a lot of that. So given that, I think that's one of the most important components of the Spot Clinic that we have at Children's Mercy, is that in addition to being sort of this medical home for surveillance for children with hereditary cancer syndromes like Li-Fraumeni syndrome, we also are there for families' questions. Parents can reach out to us with their questions and concerns, and we're there to help triage. We're accessible in between their appointments and their scans, so we can either provide reassurance or guidance for next steps. And that does, I think, take some of that pressure off of families who are trying to navigate all of this.
So how many different genetic hereditary cancer syndromes are there that you're working with, and how often does a new one come along, or we discover a new gene that's causing a series of cancers?
So in the Spot Clinic, we follow about 10 to 15 different hereditary cancer syndromes that have pediatric implications. There are a handful of others that are housed in other clinics across our hospital, but we focus really on the syndromes that have more complex screening schedules and that have cancer risks that are across multiple body systems and require more complex navigation of care there. We don't come across new ones terribly often, but occasionally, as we're sort of fully characterizing new genes at a rapid pace these days, we do occasionally discover that there might be a slightly increased risk for certain types of cancers that might warrant some additional surveillance.
Now, Dr. Weitzel, you brought a family tree, or what we call a pedigree. When I think of pedigree, I'm thinking about my cat or my dog or something like that. But this is actually a really important concept, and it helps explain how Li-Fraumeni. See, I told you I would goof that up at some point.
No, you've got it just
the
right.
syndrome. It sounds like a gang here or something. The syndrome is inherited. Walk us through what it means.
Sure. So this is something we use for illustrative purposes all the time. Frederick Lee and Joseph Fraumeni Jr. worked together at what I hope will be preserved, the National Cancer Institute, one of our more important institutes, and they saw this clustering of cancers. And what was signature, and if you look at the very bottom, circles are women and squares are men. We didn't make that up. That's just the way it is. And genetic counselors, this is their language. So you can see the childhood tumors at very young ages, so soft tissue tumors. Leukemia was once thought part of the syndrome. It's a very rare type of leukemia, hypodiploid ALL. So we now know much more about the syndrome. But it was clinically defined. When you look at the pattern, people at every generation are affected. So it's what we call autosomal dominant, and it means that you either have a 50-50 chance of inheriting it as it goes down. You see a man with a little yellow line in it, he's a carrier but hasn't had cancer. Yet his sister, his brother, his mother, and his daughter all have had cancer. And when you see the others, like the women, and the breast cancers are the youngest breast cancers I've ever seen. So they're as young as 18, and under 30 is what usually clues us into thinking about Li-Fraumeni syndrome. The other thing that Angela experienced that is relevant is HER2/neu positivity, which is only about 20–30% of most women who are young, but it's about 70% of the Li-Fraumeni cases, triple positive rather than triple negative. But nonetheless, those are the main core tumors, and then multiple other tumors can be at risk as well.
So do you have to, I'm going to ask a question that I'm going to try and spit it out correctly. We'll figure out, you'll interpret it for me. So lots of different genetic variants out there can contribute to cancers. We do screening on patients a lot, like my family has been screened for a variety of reasons. But how do I know if that Li-Fraumeni was included in that test? And is it in most screening packages, if you will, that you do?
That's a great question. So to begin with, I'll call it the modern era of genetic testing.
Yeah.
The syndromes and geneticists and genetic counselors have been around for a long time. We can just finally explain the problem and trace it in families. So the genomic revolution gave us tools to analyze this. But nonetheless, to start with, for BRCA1 and 2, which are the most commonly tested, first commercial testing was 1996. And it was 2 genes, $6,000, and took 6 months. Because of the advances in technology, we can now do 80 genes in 2 weeks for $250. So that allowed us to have the economy of inclusion. One of the first labs where I used to work at my former institution at City of Hope, we had a diagnostic lab for P53 in 2007, but we were one of the only ones who offered it at that point. But now with the multi-gene panel era, the next generation sequencing era, we can do it. And now because we know it's a partner in many different types of tumors, it's in almost every cancer panel. So if you've had anything in the last 5 to 10 years, it's almost certainly included P53.
There you go. That's like I do cystic fibrosis patients.
Yeah.
And so, we started with 10.
Sure.
And then we went, and Children's used to be one of the first centers that did the screening for us, and they did 10. That was back in the 90s and early 2000s. And then it began 100, and then 200, and now it's like 2,700 genes you get when you do the panel for CF. So that's been a really big development. Now, currently, fighting Loeffler-Mini syndrome means early detection and surveillance, like Aaron and Angela's and Aaron's daughters are getting. But in the future, is there a way to think about turning this gene off so it doesn't go? Because you mentioned it kind of gets turned off around 45 or so. Can we turn it off at, say, 5?
Yeah. Well, the challenge isn't to turn it off. In fact, we need it on.
Okay.
So it's it's not particularly straightforward.
Yeah.
And so many of the changes in that gene are what we call missense. They change one amino acid. They decrease a critical function of that gene. And one of the other problems is when it gets mutated in that way, it actually adheres to other copies of the gene, and we have an accumulation of the protein, but it's not a good protein. And so the problem is with it being the guardian of the genome, so central to just normal genetic function of a cell, that we thought we'd never be able to do anything about it. But now there are some targeted therapies coming along, in particular, for example, molecular therapies to disaggregate those pieces, the gene proteins that stick together, or to replace the function. We won't have time to talk about it much today, but there's a good story about elephants in here. Okay. And that's that elephants
I knew that was coming.
That's right. Well,
yeah,
I put it in the idea later, but it makes sense now. They have multiple copies of P53, like 7. And they're huge animals, live a very long time, both of which put us all at risk of cancer, right? But they almost never have cancer. And so there's actually been demonstration that in the blood you can detect a decreased function of P53. So something that could be transgenic to improve that might be, but it is such a delicate part of the clockwork and of all the system
and
that the real challenge is targeting.
Lots of effects about what it could be.
I don't want to get people too excited yet, but they're starting, though, to be very precise about how they can target.
I've always said I wanted to be more like an elephant, so there you go. Okay, now, Caitlin, do most people who have a gene variant want to know so they can be proactive? And how often do you meet people who prefer not to know, even if it may be a risk for their children?
So despite the hugely stressful implications of testing, most of the families I meet are desperate to clarify whether their children might be at risk. Anxiety is very high as we test parents and children and siblings and other people in the family, but in general, they'd rather know so that we can screen. But I have met a handful of families over the years that are resistant to testing for themselves and their children. And that almost always comes from a place of fear and anxiety, which I think most of us can sympathize with. So in those cases, we try to encourage and support them as best that we can.
Yeah, we just to be personal for a moment, we have a gene in our family, high cancer risk, and we had to talk to our children. My wife and I had to talk to our kids about it and say, guys, we know this is in our family now. You should go get tested. And my kids waited from go get tested pretty soon to a couple of years to decide to go ahead and be tested. And unfortunately, one of the 3 has to start doing all the early screening things. So, the fate of the human gene story. Okay, we're here to answer your questions. Send them using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's go check in now with Doc Hawk. Hawkeye, first of all, how are you?
Yep, I'm doing really well. And you know what? I would actually argue that really every good story needs an elephant in it anyhow.
Well, I like it. It's the elephant in the room, right? If you
great
don't do
beasts,
it,
for sure, great animals.
All right. So the ACIP meeting's underway. What's going on with vaccines?
Yeah.
Are they up for discussion? We're glad it actually happened, so that's good.
I think this is exciting. Again, ACIP is just a recommendation body. They pour through thousands and thousands of pages of data about vaccines coming to market and determine, is this safe, is it effective? So it is a very, very helpful committee. Only for recommendations. Again, they don't make mandates. So this is very good that they are meeting now. This was a meeting that was originally scheduled in February, is pushed back until now. They had their first meeting yesterday. They're meeting today. Hopefully we'll see some recommendations or new changes, but they are talking about everything from COVID and influenza vaccines to Mpox and things of that nature as well, plus going over other vaccines that are not on the market yet but are just being investigated at this point in time. So we'll see eventually what comes up with that.
So there's some kind of information out there that says, do we all still need a COVID vaccine, or should it be more targeted, or more particularly a vaccine against SARS-CoV-2? Because let's face it, we had a pretty mild winter around SARS-CoV-2.
Yeah.
Are we going to do more targeted vaccination for COVID in the future?
You know, I don't know. That is a good question. You know, certainly there are a lot of countries in Europe that just make it for high-risk people and not for everybody. Obviously, the recommendation for the United States is everybody 6 months and older should receive an updated vaccine. We will see what those updates are. I know that for me, particularly with my children, again, who are 18 and under, I felt it very important to give them the vaccine, not because of the acute illness and the severity of illness, because they were young, they are otherwise healthy, will probably do well. But we know there is good data to support the fact that it helps reduce the chance of long COVID. And we know you can get long COVID with any illness, whether that's with COVID, whether that's severe illness or very light and mild. And certainly I wouldn't want the heartbreak of watching my child be unable to get up and walk, do regular activities of daily life, or be out there playing and be with their friends because of long COVID or something like that. So I'm doing it more for the beneficial effect of reducing the risk of long COVID. We know that there are those beneficial effects of this vaccine, not just against the illness, but like I said, against the consequences of the illness as well.
You know, I just say, Hawkeye, I think that makes so much sense, because even this week it has been reported that long COVID is associated with early dementia now,
Yep.
and all sorts of challenges out there. And with vaccination demonstrating a reduced risk of that, I think that is a really important consideration.
Yeah.
Hey, measles numbers are still up. 561 in Texas alone, 32 in Kansas. The CDC says this is probably a severe undercount, since it's really only diagnosed in people, they go to the doctor, so he actually identifies the rash. A lot of people may have the rash and be pretty mild, especially when you're of younger age.
Yeah.
Talk to us a little bit about what you think about what's going on down in Texas.
I think that's absolutely true, and certainly we know in New Mexico too they had added recent cases, but they did state that some of these cases were previous. They're just coming to light now after the investigators are doing their epidemiology and looking at these things, and they're talking to these families, and the families talk about somebody who was maybe ill 2 weeks ago with the rash, so they're just counted now. But like you said, if it is a mild illness, or they know in the family there has been other illness, they aren't going for testing, and if hopefully they're well and not having to go to the hospital, so they aren't getting counted. So I think an underreport of these numbers is pretty accurate. So we are dealing with 561 confirmed cases in that Texas area outbreak, but we have to understand that there's probably so many more non-confirmed which have recovered, but I think that is a good point as well. And we are also seeing more cases in other states as well.
So yeah, and the answer to this is, and I think even our Secretary Kennedy even may have agreed that we actually should vaccinate against measles.
Yes, again, this remains largely a disease of the unvaccinated. The measles vaccine has been around for 6 decades. We know its safety profile, which is excellent. We know its efficacy, which is excellent. This is evidence-based medicine, and we have a plethora of evidence to support the use of this vaccine. So I think that's very good. And the other thing I was thinking about too is a lot of these patients that are coming down with measles are 18 and under. Of course, there are some that are over than 18, but you're not seeing it in the older groups of people. And I wonder if because those parents were actually vaccinated by their own parents, however, now have failed to vaccinate their children. And again, I think we always have to go back to the hospitalizations, which it's always bad to go to the hospital. You don't want to go to the hospital unless you absolutely need to. So if you can stay out, that's a good thing. And of course, these 3 deaths, and they aren't just numbers, unfortunately, they are just gentle, priceless souls that now are not with us because of this, and that could have been 100% prevented with the vaccine.
All right, we know that many of you may have questions. Let's head to Studio B this morning with Alexis. Good morning, Alexis.
Good morning. Did you just pluralize me? Did you call me
did.
Alexi?
No, I did not call you Alexi, and I didn't call you an elephant either, fortunately, even though you could be the elephant in the room. I don't know. What do I do with that joke instead? Go ahead.
We've got a question from Lin Yang Liang. Lin wants to know if genetic testing for cancer could be similar to other testing in that it might produce false positives or false negatives.
Oh, that's a great question. Caitlin, I'm going to kick that your way as a geneticist. I'm sure people ask you that question.
Yeah, it's rare. It would be very rare for something like that to happen. I mean, we can never rule out human error in a lab-based test, but in general, our technologies allow us to look fairly directly at the DNA sequence that can identify those spelling mistakes or those little missing or extra pieces that might make that gene not work the way that it should. So in general, we trust these results. We don't worry tremendously about false positives or false negatives, especially when we have, control samples from affected family members and things like that to help with the technology.
Yeah, there's lots of duplication around this, so I would say I'm going to bet you really haven't seen a lot of false negatives or false positives in your career.
Well, for P53 we have, but only false positives, and that's because it's so commonly mutated over age that it can be in our blood only. And so we discovered with the widespread P53 testing that we were finding people who didn't look like the syndrome, and they were getting tested because of different cancers at older ages, and it turned out we were able to determine that it was acquired late in life and caused something called clonal hematopoiesis. Now it turns out that might be a precursor to hematologic disorders.
So it could still be bad.
So that's. And the other is that we always think, I don't think of false negatives, I think of it looks like the problem we're trying to diagnose, but the gene didn't get reveal itself.
That's not a false positive.
That's sensitivity.
Yeah, technically, if a false positive would be an error from the liver, this is not a false positive. You are still positive.
You're still
Just
positive.
may not
it's
have the
analytically
same
correct, but clinically wrong.
Yes, I don't know that I would call that a false positive.
No, it's not a false positive.
Okay.
It's analytically correct, but clinically the wrong reason.
Yeah.
But we've learned how to deal with that.
So I like Caitlin's answer better. But actually, both answers are true.
Well, I'll
right?
clarify
Both
too.
answers
I'll clarify too. In children, we don't run into the that issue quite so often. So from my perspective, that's not something I encounter a whole lot. But certainly within the adult world.
This demonstrates a really important point, guys. This is the importance of science, because science tells you the entire set of information, and as best we know it, and then we have to draw our conclusion from it. So in this situation, you would say, well, look, we can have an elevated level of P53 in your blood as you get older. We don't know if that means you necessarily have the syndrome, or does it mean you've had the secondary thing you've described? It just means we have to do more investigation. That's the truth of science.
Well, and the other is that's why we have a multidisciplinary the entire lifespan program, and why we're partnered with Children's Mercy, because this affects children and adults working together. Lauren and I here at KU has been very active in this space. AJ Bansal, Dr. Attard, Dr. Ginn. We have experts at both places working together to decipher this complex disease.
Yeah. It's not just a simple yes no.
It's not simple.
Okay, there you go. Well, how about that one, Alexa? That's great.
Jennifer Tweed Beardsley wants to know if, since she has the BRCA mutation, at what ages should her children be tested for it?
Oh, great. Well, that's a question. All right. So I'm going to turn to our Children's Mercy counterpart here, Dr. Schwager. Help us with that, both for boys and girls.
So in general, for the BRCA mutations, we don't do a whole lot with that at a pediatric institution. Most of the time, we still discuss that as an adult onset hereditary cancer syndrome. We don't typically see it in children, and so we often recommend genetic testing around age 18 when they can, to sort of preserve that patient autonomy. And so those children can get a little bit older, have a better idea of the implications of testing and the results of that, and sort of help participate in the decision making of, do I want this information, and what will that mean for me if I test positive? So in general, we recommend testing around age 18, and then the screening kind of goes from there as they advance into adulthood.
Somebody comes into your office, they're 20, and they know they're BRCA1 or BRCA2 positive. What would you tell them?
Well, I'd tell them that we can help them to live a long and healthy life if we follow the right screening protocols. We initiate screening earlier than for almost any other thing. We know that surveillance helps in down stages, makes things more curable. And we know that after childbearing, the removal of the tubes and ovaries literally eliminates the ovarian cancer risk. So we know what we can do. We have decades now of evidence for those genes. And I think it makes it really medically necessary care. We work very hard to get over barriers to that knowledge. But I agree with Caitlin. We don't want them to know it necessarily at 18. When it's actionable, it starts to be around 25. Yeah. So know when you need to do something.
Ruth Ellen wants to know if genetic testing for cancer is connected to any outside funding and if it's covered by insurance.
Oh boy, that's always an important question.
Yeah. Well, I can say that pretty clearly that was actually one of the Affordable Care Act provisions, was genetic testing without deduction, in fact, because it was so important for identifying people. We did Lynch syndrome here not too long ago. Again, same thing. So yeah, it should be fully covered by insurance. I was on the NCCN Guideline Committee for 19 years, and then they usually go by those guidelines. If you have criteria, meet the criteria, it should be covered by your insurance like any other medically necessary care.
Was your screening covered by your insurance?
It was covered by the genetic testing
Yes,
center.
because mine was obviously covered by insurance because of my cancer diagnosis, but then because I was positive, anybody that was blood related to me could be tested for free within 90 days.
That's how I got it there.
That's awesome. All right, it works. Just say
works.
Affordable Care Act does work. Okay.
Jeremy Yenster has a question. Jeremy wants to know if having Lee Fremini makes treatments work differently, treatments like chemo or CAR T therapy.
That's a great question.
Yeah, that's a really great question. And remember, we have a limited sample size because, again, we have a limited number of people. But just as Angela has experienced, the HER2 new therapies work like they do in other women, and in fact help give us that advantage of effective treatment. It sort of equalized the playing field, HER2 positive versus negative for breast cancer. The issue is new primary tumors. So we're going to cure the cancer we have in front of us if we catch it early enough, and then we have to be vigilant for the second hit. And that's one of the other, I'll call it sine qua non of hereditary cancer syndromes, is not just this first one, but being vigilant for the second. So you want to be in a high-risk center, get that kind of surveillance. But as far as we understand, the therapies work equally well. And one difference, one exception, is we try to avoid radiation therapy if we don't need it. And so for a woman contemplating breast cancer therapy, we will encourage mastectomy rather than breast-conserving therapy because we are concerned about the radiation effect in somebody who's predisposed to sarcoma.
That could start.
So there are some therapeutic warnings of avoiding the adverse outcome, but we can still very effectively use curative therapy.
All right, excellent answer. All right, Alexis, one more question.
One more question from Marcia Francis. Marcia writes, I've heard of people without genetic predispositions being screened for cancer with a full body screening. Is that something that's on the horizon for everyone, or is it far too soon for anything like that?
Okay, so with that's a whole epidemiologic question, actually.
Yeah. So, and it's also cost, healthcare costs. It wasn't that long ago that rapid whole body CTs for $250 were the rage. You could get them. Yeah. But then we, of course, realized we're giving ourselves radiation doses that we certainly don't need. And they were finding things they didn't need to chase down. But there are some commercial firms out there that are selling people wellness, but at a great cost. They're doing MRIs just to screen. And it's not an accepted approach to healthcare at this moment. But the beauty of MRI is that it isn't radiation-based. It's magnets, after all. We have some concerns about the gadolinium exposures over a long period of time. It does accumulate. It appears to be safe. We believe it's safe. But I don't think we advocate that kind of broad screening, especially given that I'd rather focus on immunizations and all the other things that we need to make sure that everybody's getting. And then at the high end, can we get screening done? If you have a lot of cancer in a family that hasn't been explained by genetics, there are what we call empiric risks. And so sometimes we do arrive at screening more than we would. Just having a family member with colon cancer, you should be started early and go every 5 years instead of every 10 for colonoscopy. So we do adjust our sales based on what's in the family in front of us.
Yeah. You know, we have to be careful of how we use all the different technology we have and make sure that the things we're going to do are going to have a meaningful and important result. So this has been a great discussion. I am really grateful for all of our guests who came here today. I want to hear final thoughts before we go. Caitlin is a genetic counselor. What's your final thought?
So hereditary cancer is an area where knowledge truly is power, and we can drastically improve outcomes by taking a proactive approach. So if you have a personal or family history of cancer and you want to learn more about whether there might be an inherited component to that, I just encourage you to reach out to a genetic counselor in the area who can perform a risk assessment and facilitate the appropriate testing.
Yeah, I think that's exactly right. I'm going to turn to Aaron again. Thanks to you and Angela for both being on the program today. It takes a lot of courage to come on and tell the whole world about your story. So thank you for doing that. Aaron, talk to us a little bit about your final thought.
Well, I would just like to say thank you to Dr. Weitzel and to Caitlin. They have provided me a lot of peace of mind in a very difficult journey and situation. And like I said, Dr. Weitzel has changed my life for the better. I get a lot of screening now to hopefully prevent any future problems. So it's definitely helpful. So thank you.
All right. And yeah, thanks for being here today. Angela, we're glad you're here today, and especially when you have a big thing coming this week. So
Yes.
Thanks a lot for being here.
Yes, well, I appreciate you guys having me, and second to what Aaron said, like just so appreciative of Dr. Weitzel and his team. I think as genetic testing is becoming more and more available, I think it's just really important that people have the knowledge, and I think this is great what you guys are doing and spreading that knowledge.
Yeah, well, thank you very much. All right, Dr. Weitzel.
Well, I'm honored that we've had expertise at Children's Mercy and at KU, at University of Kansas, and putting the two together in a coherent program, the Heartland's Li-Fraumeni syndrome program, was really important to me and helpful. The second is there's the Li-Fraumeni Syndrome Association, one of the advocacy organizations. It's a great resource, and it's a rare disease, and was started at the same time as the Li-Fraumeni Exploration Consortium. The acronym is LIFE. And so we're working together. These two were born together, the advocates to hold our feet to the fire to make progress, and us working together to make it happen. We're doing registry research to be able to identify more and more about the syndrome. So I'm excited about the future for this, and just honestly very honored to be here at KU to be part of this Heartlands program. We sort of say we fill the donut hole in the middle of the country.
Yeah, I love that, because that map showed that we wouldn't have one in the program, so that was a really big deal, and we're glad you're there. And I think we have a headshot of everybody that's in that program.
Yeah, please, it'd be great to show the headshot of them.
Have our look at our
it's
team.
It's a team.
Yeah, and in any of these things, it takes a team to win those battles. So thank you guys. Doc Hawk, final thoughts.
Yeah, I think this is a good time to talk about, ACIP. What are they for? They are to help inform you and provide accurate information. What we have just seen on this show is to help inform you and provide accurate information. It's not to scare you, just as we heard about. If you have testing, Dr. Stites said, that just leads to more investigation that we can do to keep you safe, keep you informed, so you can make the best decisions for you and your family. Same thing when we are continuing to endorse these vaccines. We are giving you all of the accurate information so that you can be better informed for your health and your safety and those around you as well.
I'm always reminded on this program about the power of science through storytelling. Because one of the things that happens out there today is that, people kind of invent their own truths. And the problem is you can't really build on an invented truth, right? Because eventually when people don't tell the truth, they lie about things, then eventually that fails. Whereas truth and science can prevail. But we have to stop the invention of myths to help satisfy our own viewpoints, as opposed to trying to let science help us. I think what you heard today is a story of science helping bring hope to individuals who may have been very worried and very concerned, and having faith in their teams to help them through that journey. It is the power of science to help generate both hope and faith. Now, hope and faith can come from a lot of places. But when you do have a conversation about what's really happening, whether it's about the measles and the reasons for it and the treatments for it, or about a syndrome that can take young people's lives from breast cancer at an age of 18 or 19, if we don't tell the truth about it, the end result is really a failure for all of us. But it's really a failure for the individual whose life ends way too soon. The power of science, the power of faith and hope. Thanks again to all of our guests. Remember, to our audience, faith, hope, and science. We're back next week.
A walking stroke and heart attack. That's what doctors called Alex Lovely with his dangerously high blood pressure. I'm Alexis Del Cid. On the next All Things Heart, the doctor who finally diagnosed him with the condition causing it and the treatment that changed his life.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.